Brilliant. So hi everyone, welcome to the GP tutorial. I'll be starting the first section. And this is a question that comes up very commonly. And what do we need to know for GP in fifth year? And the key things you need to know is that whilst it may seem that everything from fourth year can come up in GP, UCL focus only really on the common conditions. And that's what we're going to try to cover today. So in the GP setting, remember there are limits to the investigations you can do. So that will come up a lot in SBAs and OSCEs. There are certain investigations you'll not be able to do in GP, and so that will change your management plan accordingly. As I said, UCL love testing common conditions, and including that, there are a lot of referral criteria for common conditions, such as the 2-week waits for certain cancers, and it's be very useful for you to memorize that. And lastly, there is this point, quickly identify sick patients. So what we found a lot in our SBAs last year is that because there are limits of investigations you can do in primary care, a lot of the questions UCL will give you will try to test your knowledge of what you can do and what you can't do and who needs further attention. So part of this is understanding who needs to go to the emergency department or need more help. So in this tutorial, we've mainly done it through single best answer questions followed by discussion of the answers. And we've done with the most common presentations because GP is vast, but UCL only really care about the common conditions. So we can use the chat function for the SBAs. That'll be really useful. And during the tutorial, keep your mics and videos off. And thank you for coming. Cool. Let's start with the public health section. This is the first SBA. So you're an F2 working in your local GB surgery. Your next patient is a 62-year-old female with type 2 diabetes. She feels like she could be doing more to help control her diabetes, but believes managing the condition is largely out of her control. Based on this information, what is her patient activation score? When you have an idea, just pop down your answer in the chat. Okay, so the answer is level 2. And this brings us on to patient activation score. Now, this is an extremely niche thing that UCL will undoubtedly test, maybe for one SBA a year. And it's this custom score, which has 4 levels. And this is meant to determine how self-confident and goal-orientated a patient is in the primary care setting. So level 1 is patients that allow all charge of their health to go to the doctor. They don't have the confidence, they don't have the goal orientation to manage their own health, and so they're passive. Level 2 is when patients start to gain some knowledge, but largely their knowledge is not sufficient. They can make very simple goals, but they're not really goal orientated and don't take the onus on themselves to do it. So in the previous example, the patient believed that the condition was largely out of their control, but they do recognize that they could be doing more to help. So subjectively, they would lie somewhere in level 2 because the step to level 3 means they're taking actions. They have a goal and they're working towards the goal, which this patient didn't seem to be doing. The last jump from level 3 to level 4 means the patient is even more goal orientated. They're in charge of their own health. They're having new behaviors, and the doctor is less an important factor. So this is just a score you should just quickly read and memorize. UCL are likely to test one of the question for one question. And it brings us on to the patient-centered pathway. So this person-centered pathway is a UCL creation that comes up in both SBAs and OSCEs. And it's a way to do a GP consultation that allows the patient to be autonomous, have control and really make their own decisions. So what you would do first is, if a patient has, for example, come in for the diabetes checkup, you want to explore how important the diabetes control is to them. If it's quite low, if their score is between 0 to 2 out of 10, then you'd engage in discussions about why they feel it's not very important to them. And once you understand that perspective, you can try and guide the conversation. You can tell them some of the pros of the way they're doing it, some of the cons, and try and allow the patient to form their own choice. So, but if the patient recognizes that it's very important, if they say a score of 7 or more, you can move on to the next section, which is how confident are they in controlling their diabetes. So this again is scaled out of 10. If it's more than 7, you can use this acronym SMARTER to set up an action plan. And then once you come up with the action plan to finish the consultation, you can recheck their confidence and hope that it's increased closer to 10. If it's less than 7, then you start with the patient to start problem solve and try and solve any barriers they may have to try and increase their confidence. If this still hasn't helped, it might be a point to try and rethink the goal, maybe to reduce the expectations of the goal to a lower setting so that they can achieve this and work from there. And that's what we discussed here. And these slides will be available afterwards, but these are general phrases that you can say in an OSCE to try and make your patient-centered pathway smoother. And we talked about SMARTER goals. So when setting a goal with a patient, you want to make sure it's specific to what they want, it's meaningful, they can achieve it, there's a time pressure, and that it can be readjusted and evaluated. And also here's another acronym, AWS. Now AWS comes up in every single mark scheme in regards to the patient-centered pathway. And more so than just, these aren't really questions you ask, these are your general marks over the whole station. So if you're asking open questions, allowing the patient to lead the consultation, you'll get a tick. If you're affirming how the patient's feeling and normalizing their worries, that'll give you a tick. If you're then listening actively to the patient and reflecting on how they can make their life easier, that'll give you a tick. And if you're chunking, checking, and summarizing, that'll give you all the marks you need for this or section. So it's nothing you can do specifically, and it's more about your communication skills and how you go through your consultation. And for this next section, there are some minor stat stuff that is rare to come up, but it's good to know. So the years of life lost is a measure of how many years of life you've lost because you've died prematurely. Years lost due to disability is years lost because your disability or chronic condition has been having consequences. And to get a DALY, which you might have heard of, which is the years of potential life lost due to dying early or due to disability, you add both of those things we've discussed. And globally, the greatest cause now is ischemic heart disease, which is in keeping with what we're really seeing around the world. Cool. Now for this next section, we're moving on to screening. So a 49-year-old woman registers as a new patient at your practice. She asks you about what health screening she should be attending. What is the most accurate advice you'd give to her regarding NHS screening programs? So feel free to pop your answer in the chat. Well done. The answer is indeed D. So this is attended for a mammogram every 3 years from 50 years and a cervical smear every 5 years from 50 years. So patients are invited for breast screening every 3 years from 50 to 70. And they can continue this over 71, but this has to be requested. And what they do as part of the screening is a clinical examination and also a mammogram. And this mammogram comes in 2 views, which is craniocaudal, so from top to bottom, and a mediolateral oblique, so which is from the side. And with these 2 views, they can classify whether it's high risk or not and move on to further investigations. And even though this program is planned to be expanded, this hasn't happened yet. So for your exams, you just need to remember 50 to 70. Now, when it comes to the smear, this is between 25 to 64. From 25 to 49, the smear is done every 3 years. And this is first to test for HPV, which is high risk for cervical cancer. And then if this is positive, then they will do cytology. From 50 to 64, though, this reduces to every 5 years because the risk of cervical cancer goes down. In certain circumstances, patients don't conform to these every 3 years or 5 years. So in HIV positive patients, you have to do smear test every year because it increases your risk of having HIV increases your risk of invasive cervical cancer. If you're pregnant, you need to wait 3 months after you've given birth. And these are the key facts for this screening. For bowel cancer screening, men and women are invited between 60 to 74, and they're sent a home FIT, so a fecal immunochemical test. So this will recognize small microscopic amounts of blood in the stool, and this is sent home every 2 years. So there was a small initiative to do a one-off flexi sigmoidoscopy, but this never went forward. So the home fit is what you need to remember. And if you remember to last year's vascular surgery, when men turn 65, they're invited for an abdominal ultrasound. And what this measures is the diameter of the abdominal aorta. If it's found to be less than 3 centimeters, no further action. If it's between 3 to 4.4, they need to have a ultrasound scan every year. If it's 4.5 to 5.4, they need to have it every 3 months. And if it's above 5.5, they need to be referred to the vascular surgeons. And this is under a 2-week wait because you're worried about the risk of the abdominal aorta rupturing. So there's actually another criteria that would warrant you to be referred 2-week wait to vascular, and that's if it's grown more than, I think, a centimeter in a time frame. So if it's showing elements of fast growth, then it's more high risk and needs to be seen urgently by the vascular surgeons. Medical forms. Now, UCL do throw in 1, maximum 2 questions in the SBA about this. And this is the first SBA to cover. A 32-year-old man who works in a local dye factory visits the GP complaining of lower back pain. The GP tells the patient to take NSAIDs and encourages him to stay active. He's been off work for 3 days and asks the GP to sign him off work while he recovers. What should the GP do? So we've got an A here. Any other takers? No, that's fine. A is the correct answer, so you'd encourage him to self-certify for up to 7 days and book a follow-up. So medical forms. Patients can self-certify for a period of up to 7 days for any illness. So this can be back pain, this can be having a viral urti, being a bit ill, having the flu. And fit notes count for consecutive days, including non-work days. So this can include the weekend. So there are certain forms just to be aware of. A self-certification form, the employee themselves fill this out to get sick pay from the employer. A fit note, which is a Med 3 form, is signed by a doctor after the initial 7 days of self-certification to get 7 more days of sick leave. A Med 10 form is signed by a doctor, and this is for an inpatient stay, and this can be any length. And lastly, a MAP B1 form is maternity leave within 20 weeks of delivery. So just be aware of this, just memorize this and get the answer right in your SBAs. It's a good, easy mark to get. DVLA. So there is a set of guidelines you have to remember, similar to last year, because this does come up in GP consultations and GP settings a lot, and they want you to know the basic idea of this. So with this, the 62-year-old retired female patient was treated with a PCI following a myocardial infarction. She's been started on new meds and is clear about the instructions, but wants to know if she'll be able to drive. What are you going to tell her? B is one answer we've got, and it's very close. Very close, well done. Yep. The answer is D. So it is 1 week from a successful PCI, but they do not have to inform the DVLA. So these are the criteria. If a patient has, well, generally I should say the HGV is good if you memorize it, but it's asking a bit too much to come up in an exam question. I would focus first on memorizing the general criteria for the majority of people who drive normal cars. And if you want to be holistic, then maybe remember the HGV criteria. So with a first seizure, you have to be 6 months seizure-free before you can drive. If you're epileptic, you need to be 12 months seizure-free. If you've had a stroke or TIA, you have to take 4 weeks off, but you do not need to inform the DVLA. You also do not need to inform for an explained syncope, where you have a reason for your syncope, for example, a vasovagal. But if it's unexplained, 6 months off driving. And there are also some criteria about cardiac stuff, such as MI or unstable angina, that you can remember here. Now let's move on to the first medical topic, and that's cardiology. So you had a lot of cardiology last year, obviously, but for this year, we're trying to refine only the knowledge that is useful in a GP setting. So this will come in the form of stable angina, chronic heart failure, and noticing an MI, not necessarily the management of an acute MI, but knowing when a patient is presenting to a GP practice with an chest pain, and then referring that patient to secondary care. So dealing with a sick patient and the common conditions you see chronically in people. So this is the first one. A 52-year-old man presents to his GP complaining of central constricting chest pain. This lasts for 30 minutes, about 5 hours ago. The pain was worse when he was walking around, and an ECG showed an ECG at the practice, which it must be a good practice to do ECG, showed ST depression and T-wave inversion in leads 2, 3, and AVF. How should you manage this patient next? So whenever you're ready, pop your answer in the chat. We have an answer for B. Any other takers? That's fine. The answer is indeed B. So you want to prescribe 300 mg aspirin and call for an ambulance so that the patient can be immediately assessed at hospital. So NICE have guidelines for the assessment and diagnosis of suspected cardiac chest pain. So when presenting to a GP practice with acute chest pain, what can they do? Well, they can give a GTN spray to try and make the chest pain better. They can prescribe aspirin 300 mg, the loading dose, to get the MI management pathway started. And if they have the capabilities, they can do an ECG. Now, even though the acronym for the management of MI has oxygen, this is definitely not recommended in patients that have SATs 94 or above because it leads to worse outcomes. So only give oxygen to patients that need it. And in GP, you can still take basic obs, you can still do an ECG. So remember to try and do that. In terms of referral to secondary care, if they're currently having chest pain that sounds cardiac in nature, or they have chest pain in the last 12 hours with an abnormal ECG, which is what the previous patient had, then call an ambulance for emergency admission. If their chest pain was about 12 to 72 hours ago, you can be a bit more relaxed, but you still want to refer them to a hospital for same-day assessment. So that could be to STEC as opposed to A&E. And if the chest pain is more than 72 hours ago, you'd want to do a more holistic assessment from the practice. You can refer them for an urgent ECG, get some urgent blood like a trop, and then decide further what you want to do and if they need further evaluation. So remember, stuff can still be done in the GP practice, and you need to recognize when a patient needs emergency care. Next question, and this is something that will come up in GP because they tend to be in charge of this stuff. So a 6-year-old man attends for a review of his medication following an MI 2 weeks ago. He's asymptomatic, has normal ventricular function, and his medications include aspirin, clopidogrel, ramipril, atorvastatin. What extra drug should be considered for this patient? Fantastic. We have E as the answer, and it's indeed bisoprolol. So this has the makings of a prime 10-minute OSCE station and is the secondary prevention of MI. So following an MI, NICE has a set of criteria they'd like GPs to follow so that the patients are best dealt with and we prevent further risk of cardiac insults. So as with any OSCE, you'd start by discussing in this consultation lifestyle changes. So smoking cessation, smoking is a big risk factor for cardiovascular disease, healthy diet, aim that them have at least 150 minutes a week of physical activity, lose weight, keeping alcohol. This is the general stuff that doesn't just apply to MI, it applies to a lot of stuff like diabetes, kidney disease. But specific to MIs, patients who've had a myocardial infarction should be offered a cardiac rehabilitation program. And this just is a exercise program in essence and involves other healthcare professionals, but it's a buzzword that'll be useful to say in your OSCE. And there are evidence-based drugs that should be given following an MI to reduce the risk of further cardiovascular events. In this scenario, the patient was on an ACE, they were on dual antiplatelets, they were already on the statin, and what was left was a beta blocker, which is bisoprolol. So well done for getting that right. And none of these other drugs are beta blockers, so that wouldn't be the right answer. Now, staying with drug treatment, a 6-year-old man has been diagnosed with chronic heart failure due to left ventricular systolic dysfunction. He has a previous history of MI. He's currently being treated with aspirin, atenolol, furosemide, ramipril, and simvastatin. What's the single most appropriate next treatment step? When you've had a think about it, feel free to put in a chat or directly message me on the chat. So we have an answer of D. Any other answers? But that's okay. This is a challenging question, and the answer is actually B. Oh, well done. Just before I said it, the correct answer came in. So the answer is B. If we go through this question, add losartan. The patient's already on an ACE inhibitor, so we don't need to add an ARB. Increase the dose of ramipril. I guess we can consider this, but there is a more urgent change that can be made. Spironolactone, yes, that will be the next drug we want to add, but the patient's current treatment can still be optimized. And E is a further step even after spironolactone. So with B is that atenolol is not actually licensed for heart failure, and it's not cardioselective. So patients that who are already taking a beta blocker for angina, hypertension, develop heart failure with systolic dysfunction should be switched to either bisoprolol, carvedilol, or nebivolol. And this, more often than not, is bisoprolol. So that will be the first step we do to change that. And then if that's still not helping, we can move on to adding Spiro. So as with a lot of things in GP, this is very focused around guidelines and what NICE wants them to do. So if we suspect chronic heart failure, what do we do in the GP setting? We first take a detailed history and do a clinical examination. After that, we move on to bloods, and we have a blood test that's very powerful in detecting heart failure, and this is NT-proBNP, and this is a marker of heart strain, particularly left heart strain. So once we've done this blood test, on the side, you can also do ECGs, X-rays, urinalysis, peak flow spirometry. But the key is this NT-proBNP. If it's very high, we can refer them urgently to be seen within 2 weeks by a specialist. If it's in that intermediate category, they can wait a few more, so we can refer within 6 weeks. And if it's less than 400, you can be very confident that this is not heart failure, and you start to consider other diagnoses. So what does this specialist assessment compose of? To diagnose heart failure in the first place, you need an echo, so that's the key thing, and the echo will confirm heart failure. It will identify the severity, see if it's caused by any valvular dysfunction, and identify what can be done about it. The echo can also exclude heart failure, and in that case, you follow the low NT-proBNP gut pathway. And how is it managed? Well, the first thing is to do, a lot of patients with chronic heart failure will present with peripheral edema, and that can include fluid in their lungs sometimes, and this can make it difficult for them to move, to breathe. And diuretics offer an opportunity to alleviate these congestive symptoms and get rid of the excess fluid. So once we've done this symptomatic diuretics, we move on to what's the type of heart failure. Is it HFrEF or HFpEF? If it's HFpEF, this has a worse prognosis. It's more difficult to manage. You try and manage the comorbidities. There is emerging evidence that an SGLT2 inhibitor is effective, but the evidence is not very clear-cut on that, and it's a very emerging new field. If it's a reduced ejection fraction, then there are clinically proven drugs that work to help it. You start by offering an ACE inhibitor and a beta blocker, and if these two don't work, you can move on to mineralocorticoid receptor antagonists like Spiro. And for both HFrEF and HFpEF patients, we have this personalized exercise-based cardiac rehabilitation that we discussed before. Very good buzzword to mention in any cardio-related station. Now, this forms the basis of heart failure management, but if it's not working, they really need specialist advice. They need to be put on later line drugs, so sacubitril, valsartan, the neprilysin, ARB is an option, ivabrandine's an option, hydralazine nitrate for African Caribbean descent in particular, where the evidence is strongest, and digoxin. But this is all done by specialists. What you'll get asked in your Year 5 GP questions is mainly about managing comorbidities, the diuretics, the ACE inhibitors, beta blockers, and Spiro. Apart from that, it's extremely unlikely. Let's move on to hypertension now. A 60-year-old man with hypertension has been consulting you for the last few months. Achieving optimal control has been difficult. His current treatment regime includes maximum doses of amlodipine, ramipril, and indapamide. This is not working, so you want to introduce a fourth-line therapy after carrying out some blood tests to see where you should go. Using are normal, but potassium's 4.3. What medication should you introduce next according to the guidelines?
Oh my God, wait, what happened? Oh.
Fantastic, a flurry of C's, and that's the correct answer. If you remember back to your last year, the infamous hypertension guideline graph. So if you're less than 55 or you have type 2 diabetes, you start with an ACE inhibitor or an ARB. If you're over 55 and no type 2 diabetes, or you're of Black African or African Caribbean ethnicity, the evidence base is weaker for these, so you start with a calcium channel blocker. Step 2 will be adding another drug. Step 3 will be a 3-line therapy, and where we were was step 4. So potassium in this case was less than 4.5, so we decided to add low-dose Spiro. If it was more than 4.5, though, you'd add an alpha or beta blocker instead. And if in primary practice the BP is not controlled on 4 drugs, send them to the cardiologists for a specialist review. So hypertension is very easy for them to ask in the GP setting. Memorize these guidelines and you'll do absolutely fine. Now, a review of your practice's record shows a 50-year-old Bangladeshi man invited for a full formal cardiovascular risk assessment. They used the Q-Risk-2 score, and his 10-year risk is 12%. He tells you that his father suffered an MI, and you give him lifestyle advice and do some lipid modification therapy. What's the single most appropriate daily drug regime? So this is testing your knowledge of the different preventions. Great, we have answers of D, and this is the correct answer, is the 20 mg primary prevention dose of atorvastatin. There are 2 ways to manage hyperlipidemia. We have primary prevention, which is in this case, he has not suffered an MI, and you're trying to prevent an MI because you're worried. And why are you worried? You're worried because his Q-Risk-2 score is more than 10%. And in that case, start 20 mg once daily as atorvastatin. And then you monitor him with blood tests. If this certain marker has not fallen, then titrate upwards. But there is a different dose for secondary prevention, and this is following an event. So if he's had an MI and you're starting secondary prevention, you do atorvastatin 80 mg. So this could also come up in SBAs, and so you know the difference between primary, secondary, and tertiary prevention. So primary, as we said, is before it happens to prevent the risk of, let's say, an MI. Can include diet, exercise, lifestyle advice, but also atorvastatin 20 mg has been proven to be effective. Secondary is very soon after the disease. So once you've had an MI or a stroke, there are drugs you start from that point on. And these not only prevents further symptoms, but also prevents further disease. So that can include some of the stuff mentioned here. And tertiary is far after the disease, so it prevents sequelae. So PCI or CABG is a tertiary prevention of further cardiovascular disease. And so is cardiac rehabilitation. So it's harder. The difference between secondary and tertiary is a bit harder, but just remember secondary prevention as for the drugs following an MI to make it easier. So we're moving on to the other one we discussed, the other main common condition in cardiology, and that's stable angina. So you see a 53-year-old man with angina. He's had more episodes of exertional chest pain, but right now is pain-free. He's taken aspirin, bisoprolol, GTN, and his blood pressure is 134 over 82. His pulse rate is 68 and regular. What medication should we start in this patient? We have an answer of D. Any other takers? We have a couple of E's. I'll give 5 more seconds for any other answers. So unfortunately, the answer is A, and this question is a classic one which tries to catch you out, and its purpose is to test if you're reading every single part of the question or not. So it's like one of those asthma situations with beta blockers. So the offender in this case is the beta blocker again. So whoever said E had the right idea of a calcium channel blocker as the next step, because they're still experiencing exertional chest pain, not helped by the bisoprolol alone. But adding diltiazem with bisoprolol will increase the risk of bradycardia and possibly heart block. So we do not combine those two drugs. We instead use a different class of calcium channel blockers, such as amlodipine, as second line. But it's correct to remember that diltiazem is the preferred calcium channel blocker in angina, but not when there is a beta blocker there. Then you move to amlodipine. So here are the nice guidelines. Offer a beta blocker or calcium channel for first line treatment of stable angina. If the person can't tolerate it, swap it to the other one. If the person's symptoms are not controlled, use a combination of the two. If the person isn't helped by these two, then it's a more complex set of criteria that can use any of these 4 drugs. But for 5th year, they will not ask you about these 4 drugs. They will try and catch you out with bisoprolol and adding diltiazem or amlodipine. So always read the drug history carefully. So respiratory now. The first one is a 36-year-old woman presents to the GP surgery with an acute flare of asthma. She's feeling breathless and wheezy. Which one of the following signs on its own would prompt you to have her admitted as an emergency? So again, this is a question testing if you can identify an emergency referral. Great, we have multiple answers of B, and that is correct. Pulse oximetry showing O2 sats less than 90. That is worrying and needs emergency referral. Peak flow reduced to 60% of the usual would not fit the criteria. That's moderate. Rest rate is 20. It's not raised enough. It's only mildly raised. Resting pulse, yes, fits tachycardia, but not the asthma threshold of tachycardia. And wheeze present throughout both lung fields. Yes, this will be uncomfortable. This is a symptom you have to think of, but it's not an emergency symptom, as asthmatics commonly are wheezy. This is the graph, this table you definitely remember from last year. Moderate ranges 50 to 75 for the peak flow, but more severe ones are under 50, in particular under 33, which is life-threatening. The rest rate and pulse we need to remember is 25 and 110. And the key in this question was the O2 sats less than 92. That is life-threatening feature and needs emergency attention. Yeah, and it's unlikely they'll test you with near-fatal asthma in the context of GP, but bear in mind, asthma happens in the pediatric setting, and that does need to be remembered for emergency management. But we'll have more of that in the pediatric talks in the coming weeks. So this is very GP question. A 22-year-old asthmatic comes into the practice for their review. He explains that he's been using his blue inhaler twice a week for the last month after exercise, and he's currently taking beclomethasone and salbutamol. He's compliant, fit and well. What should you do next in their management? Excellent. We have a correct answer of B. Now, this is one of those questions that wants to catch you out because it's the simplest answer, which is first, which is review inhaler technique. You want to make sure they're taking the inhaler correctly. UCL love it because they want to make you behave like better doctors. So first, you'd review the inhaler technique to make sure they're optimizing the medication they are taking. You'd consider, the first thing you'd always do is review inhaler technique, but if they were taking their salbutamol more than 3 times a week, then this is a criteria for stepping up treatment. And this can include increasing your dose of beclomethasone or following other drugs in the pathway. So how do we diagnose asthma? If the patient's more than 17, the first questions to ask in the history is to ascertain whether they are constantly like this or there's a discrepancy between days they're at work and days that not at work. And if there is a discrepancy, send them to the occupational asthma specialist because there is a trigger in their workplace that is causing this. Patients should undergo spirometry with bronchodilator reversibility. The pattern in asthma is obstructive, so the FEV1 is low, but the FVC is normal, so that results in a reduced ratio. Whereas in restrictive, FEV1 drops, FVC drops more, so the ratio is maintained. Reversibility after taking the bronchodilator like salbutamol can show either a 200 ml volume increase or a 12% rise. Patients can also undergo FeNO testing, so 40 parts per billion is the cutoff. For younger pediatric patients, it's 35 for the FeNO testing, and patients less than 5, you do not diagnose them with asthma. You'll have more of this, of course, in the following weeks, but they should be referred to as viral-induced wheeze. And of course, this can develop into asthma, but you don't do it under 5 years old, these investigations. Another lovely, nice pathway for children are between 5 to 16. First step is doing spirometry. Is there an obstruction? Yes. Is it reversible? Yes. They have asthma. If it's not reversible or spirometry doesn't show an obstruction, go on to FeNO testing, because there is diagnostic uncertainty. And if FeNO shows more than 35 parts per billion and there's variability in peak flow readings, you can diagnose them with asthma. If spirometry doesn't show obstruction, FeNO is negative, there's no variability, it's extremely unlikely to be asthma, so consider alternative diagnoses. Here is the treatment escalation. We start with PRN SABA. We add an inhaled steroid like beclomethasone, and this can be low dose and medium dose and high dose. This is not working. Add a LABA and assess their response to the LABA. So if they have a good response to the LABA, continue it. If it's inadequate, increase the corticosteroid dose and stay on the LABA. If there's no response to the LABA, stop it and pursue other pathways. So this can be a leukotriene receptor antagonist, for example. And this keeps going up until daily steroid tablets. So at this point, if they're needing oral steroids, they need specialist referral. So it's unlikely UCL will go past the LABA stage. So even though it's nice knowing this, to make your knowledge better in general, it's unlikely to be questioned past the labo stage. So a 55-year-old man has COPD, remains short of breath despite using inhaled salbutamol. His FEV1 is 60% of predicted. He has no history of atopy and asthma. What is the single most appropriate additional maintenance treatment? So he's already on SABA. So what should we do next? Excellent. I'll give 5 more seconds for any other answers. Fantastic. So I've got an answer of B here, and that is indeed correct. Inhaled LABA and LAMA. So another treatment guideline. So with COPD, you start with a SABA or SAMA, most commonly SABA. And then you try and assess if there's any features that means an inhaled steroid would be useful. So that includes asthma, atopy, raised eosinophils, variation FEV1, or diurnal variation in peak expiratory flow. If the answer is yes, add a LABA and ICS. If the answer is no, do a LABA and LAMA. And then if this is still not working, regardless if they're atopic or not, we put everyone on the same treatment plan, which is SABA, and then LABA plus LAMA plus ICS. You probably remember this from last year, but this is very GP-esque and can come up. So now moving on to infective presentations in RESP. So 85-year-old nursing home resident has community-acquired pneumonia with a high CRB score of 3. She and her family request active treatment, but don't want hospital admission. She has no allergies. A COVID-19 test is negative. What treatment? What is the first line recommended treatment? So this is testing your memory of the CURB score and the subsequent treatment regimes for pneumonia. Any takers? I'll give 5 to 10 more seconds. Okay, we had a flurry of answers. We've got a good mix between C and B, but the answer in this case is actually E, coamoxiclav and clary. So that's because the CURB score is the CRB score is actually 3. So urea you can't really do in primary care. So a score of 3 is very high, and we class this as high severity pneumonia. And if you remember from last year, what we do in that case is coamoxiclav and clarithromycin. If the CURB score was 2, we could give amoxicillin and clarithromycin for 7 to 10-day course. If it was lower than that, 0 or 1, we could give amoxicillin for 5 days. So this is very severe and needs the appropriate antibiotic regime for it. Okay, so that's the end of my section. I'm going to hand over to the next tutor, but while the tutor sets up, could everyone scan this QR code and give the feedback for my section while we're waiting for the other tutor to set up? So I'm just going to give 10 seconds for everyone to scan this, and then I'll stop screen sharing. Thank you again for sticking with us and filling out the feedback. Perfect. I'm going to stop screen sharing now.
Okay, great. I'm just going to try share my screen. I think that might be easiest. Okay, can everyone see that?
Yep, we can see.
Yeah, okay, great. Okay, can everyone still see that?
Yep.
Okay, perfect. So hi everyone, I'm Emma and I'm also in final year, and I'm going to start my section with MSK. So MSK is really common in GP, and you see it all the time. So just as general advice, it's usually quite good to be quite comfortable with all your ortho exams because it comes up a lot. So the first question is here. So a 60-year-old female with osteoporosis comes to see for advice on taking alendronate 70 milligrams once weekly, which has been prescribed by her rheumatologist. Which piece of advice regarding this formulation of alendronate is correct? And I'll give you a few minutes to write in the chat. Okay, I can't actually see the chat. Oh, there we go. Okay, great. So yeah, the answer is A. So something that's quite important with bisphosphonates is that particularly alendronate is that the patient has to take it on an empty stomach, sitting upright with a glass of water. And easiest thing is first thing in the morning after they've been fasting all night, and then make sure that they don't lie down for half an hour after they've taken it. And it's because it can cause severe esophagitis. So this is something that can also come up as an OSCE station. So it's good to sort of be familiar with bisphosphonates. Right, and in terms of osteoporosis management, this is quite a good flow chart and just showing you what steps you might take. And the first big investigation that would be done is a DEXA scan. And if someone can't have a DEXA scan for whatever reason and they have had a fragility fracture, you can give them zoledronic acid, which isn't an oral bisphosphonate. That's one that's given usually once yearly by an intravenous infusion. But then if a patient has a T-score that's less than 2.5 on their DEXA scan, then zoledronic acid is usually the first line. And then after that, you can sort of keep going down in terms of second line and third line treatments. Okay, so next question. A 68-year-old comes to see you complaining of right foot pain. On examination, his temperature is 36.4. The metatarsophalangeal joint of the right big toe is red, warm, and very tender to touch. The hyperemia extends over the dorsal aspect of the right foot. What is the single most appropriate management option? Any more answers in the chat? Yeah, okay, so the answer is E. So this is quite a classic picture of gout, and NSAIDs are the first line in management of gout. And gout is a clinical diagnosis. You don't need to do any investigation, so you don't need a foot x-ray. But NSAIDs would be the first thing that you're prescribing. Okay, next question. A 42-year-old woman complains of pain in her palm and the inability to move her right index finger fully over the last few days. On examination, there was some thickening in her right palm and her finger would not fully extend. Passive flexion was greater than active. what is the single most likely diagnosis? Any answers in the chat? Yeah, okay, so the answer is D. This is tenosynovitis, which is inflammation of the tendons in the sheath. And the symptoms are sort of pain, swelling, difficulty moving the joint. And it can result from an infection, but usually it's secondary to acute or chronic inflammation from something like diabetes or overuse is very common. Okay, next question. A 55-year-old man develops severe back pain radiating down his right leg. He has no bladder symptoms, but on examination, he has weakness of dorsiflexion of his right great toe, grade 4, and some weakness of eversion of his right foot. Which of the following options represents the single most reasonable practice in primary care? And I'll give you a few more seconds to put anything in the chat. Oh, okay, so the answer to this one is that you need to refer him in for same-day admission, and back pain is something that comes up a lot in GP because it's very, very common, but the important thing with it is when knowing if it's sort of very benign musculoskeletal back pain or if you've got any red flag symptoms, and here the most important thing to rule out is cauda equina. And I think there should be a slide. Okay, there might be another one, and then there's a bit more going through back pain. So we'll do the next question first, and then we'll go through back pain in a bit more detail. Okay, so a 48-year-old heavy goods vehicle driver has a low back pain on and off for 4 years. On each occasion, the pain will cause him to have a few days off work, but gradually settle. On this occasion, it's been present for 10 days and he is unable to work. He has no other medical history, no systemic symptoms, no neurology, and the pain does not wake him. Which of the following referrals represents the single most reasonable practice in primary care? Direct access MRI is not available in your area. And just a few more seconds to put anything in the chat if anyone wants to put any answers in. Okay, so the answer to this one is refer for physiotherapy. And this is a very typical history that someone might give for MSK back pain. And with no red flags, your first line treatment is going to be physiotherapy. You may want to prescribe someone painkillers as well, depending on how severe the pain is, but physiotherapy is the first line treatment for this kind of back pain. So in terms of back pain, it's really important you know the red flags, and anyone over the age of 50, if they've got any unexplained weight loss or history of cancer, then you might be worried about a bony metastasis. And something that's also important with that is musculoskeletal back pain is very commonly lower back pain. Sometimes you get thoracic back pain, but in someone with a history of cancer with thoracic back pain, you really want to be thinking and ruling out any kind of bony cancer. And yeah, you can sort of read through this full flow chart, but you need to make sure you don't have any red flags for cauda equina. So urinary or stool incontinence or urinary retention. Classically, it's stool incontinence and urinary retention, but any sort of neurological weakness or deficit should really be raising alarm bells, and you would want to send someone in for assessment and in hospital. And these slides will go out to you, so you can go through these, but the red flags are sort of the most important thing to learn in terms of back pain, and knowing what back pain sounds serious and what back pain is much more benign. So like I said, cauda equina is something that you really want to worry about and rule out. So you might get severe progressive bilateral neurological deficit, and urinary retention, again, is common. If you've got any sort of urinary retention or incontinence or any fecal incontinence, or any saddle anesthesia, so perianal or perineal sense or loss, you would want to send them straight into hospital for query cauda equina. And other red flags are thinking about maybe if someone has a spinal fracture, so have they had any history of trauma, any structural deformity, or if they've got any bony tenderness on examination. And in terms of cancer, again, like I said earlier, someone being over the age of 50, again, sort of localized tenderness or sort of this severe unremitting pain. And if they've got any other red flags for cancer, like weight loss or night sweats, anything like that, and a past history of cancer, and the sort of 5 cancers that classically metastasize to bone can be remembered by the Bs, except only actually 2 begin with B, but breast, bowel, lung, brung, prostate for prostate, renal and thyroid. So those are the ones that if someone's got a past history of any of those cancers, you want to be really thinking about, could it be bony metastasis? And then any red flags for infection or abscess, so fever, a history of diabetes, history of IBDU, they might have a ileoceous abscess, and any kind of immunosuppressants or HIV. Okay, so in terms of gastrointestinal, again, quite a common presentation to GP. And here's the first question. So a 32-year-old woman attends your surgery having experienced 7 months of bloating and recurrent left iliac fossa pain. She finds her symptoms are made worse by eating and relieved by passing stool. What is the single most appropriate dietary advice to give her? And if anyone wants to send some answers to the chat. Ooh, okay, sorry. So yeah, the answer to this one is increase intake of oats. And you actually want to advise to decrease intake of things like fizzy drinks and black tea, because this is a very classical history of IBS. So IBS, in terms of diagnosis, if you have abdominal pain that's relieved by defecation, or abdominal pain with any sort of bowel frequency and stool type, but changes to someone's bowel habit, +2 of altered stool passage, abdominal bloating, exacerbated by eating, and passage of mucus. So this scenario is a very classic IBS case. And in terms of primary care, the things that you would want to do is you want to do a full blood count, ESR and CRP, and TTG antibodies, and you'll know what you're looking for there. Yeah, so your TTG antibodies, you're looking for to see if someone has celiac disease. And obviously your investigations might be slightly tailored depending on the patient that's in front of you. If someone's younger, you might be thinking more celiac. And for anyone who's older, you'd definitely want to do a full blood count. And these are some sort of red flags in terms of if you get a patient that gives a very classic IBS history. And doctors often say that it's quite rare for someone over the age of 60 to get a new diagnosis of IBS. So if someone over the age of 60 is having these IBS symptoms, you need to investigate them for bowel cancer, ovarian cancer, and particularly if they've got any other symptoms of rectal bleeding, weight loss, or any family history. So just something to bear in mind. Really look at the age of the patient. Are they, much younger, sort of in their 20s, or 65? You're thinking quite different things, but always good to keep the red flags in the back of your mind and make sure you're getting them in the history. Okay, and so in terms of dietary advice for IBS, dietary advice is really important, can make a really big difference to people. So you want to be telling them to have regular meals and avoid missing meals and trying to eat sort of multiple small meals a day. And drinking lots of fluid, particularly water, caffeinated drinks, they sort of restricted to 3 cups a day, and reducing alcohol and fizzy drinks can really help alleviate symptoms. And it can be helpful to limit the intake of high fiber foods, so wholemeal or high fiber flour, and also reducing resistant starch. Often patients will know what sort of things particularly have triggered them in the past, but these are quite good general advice for people with IBS. And the reason why oats was the answer to the previous one is that people with wind and bloating can find it quite helpful to eat oats. It can help alleviate those symptoms. Okay, so next question. A 65-year-old lady presents with a 3-month history of right-sided abdominal pain associated with a change in bowel habit. She complains that her bowel movements have become more loose and frequent. Her blood tests show mild microcytic anemia. What is the single most appropriate management option? Yep, a couple of takers for A. So yeah, A is the answer. The thing that you're really worried about here is bowel cancer. Obviously multiple things that it could be, but the things that are particularly worrying are this change in bowel habit, someone over the age of 65, and the fact that her blood tests are showing this microcytic anemia. So the first thing you'd be doing is doing an urgent colorectal referral. So there we go. Okay, so in terms of 2-week wait for colorectal cancer, this is a really important one to know. And the guidelines change depending on the patient's age. So if you have someone who is over 40 with any weight loss and abdominal pain, or someone who's over 50 and any rectal bleeding, unexplained rectal bleeding, or anyone over the age of 60 with some sort of anemia or sort of change in bowel habit. And if there are any 2-week wait guidelines to learn, definitely these ones, because they do come up a lot. So in terms of 2-week wait, like I said before, if they're age 50 or over with unexplained weight loss and abdominal pain, 40 and over, sorry, 50 and over with unexplained rectal bleeding, or 60 and over with iron deficiency anemia or changes in their bowel habit, or anyone who has a positive FIT test, you'd refer. And also you maybe want to consider a referral for patients under 50 with rectal bleeding and unexplained abdominal pain, change in bowel habit, weight loss, iron deficiency anemia. So it's always one to keep in the back of your mind with any changes in bowel habits. Okay, and are there any questions so far on any of the gastro things that we've gone through? Do just put them in the chat or speak out. Very happy to answer them as we go. So in terms of psychiatry, moods, so anxiety, depression, those sorts of things quite commonly come up in histories, and also suicide risk assessments and things like that. So we'll go over some of these things as in the next few questions. So here's the first question. Mr. Smith, 72, has been feeling very low in mood for the past 3 months since his dog passed away. He's been suffering from insomnia and struggles to motivate himself to do his daily tasks. On prompting, he admits that he's lost weight due to lack of appetite. What is the most suitable pharmacological treatment for Mr. Smith? This can be a bit of a hard question. Any more answers? No, okay, so I completely see why we had D, but the answer to this one is actually mirtazapine. And the reason for this is because it can be very useful in older patients with insomnia and weight loss. So that's just sort of one to know in the back of your mind as it can come up. Okay, next question in a similar vein. So a 28-year-old man who's frequently attended in the past with multiple somatic complaints is diagnosed with generalized anxiety disorder. He's initially treated with a low-intensity psychological interventions, which unfortunately fails to improve his symptoms. What is the most appropriate medication to offer her next? Him next, I should say. Anyone want to put any else? Yeah, okay, so we've had a couple of takers for E. Yeah, so the answer is E. Sertraline, it's first line, along with paroxetine or citalopram, but in general, sertraline is your first line pharmacological intervention after any psychological interventions haven't worked. And one of the important things to know about sertraline as well is, particularly when starting it in younger patients, you want to make sure that you book them in for a follow-up appointment in about a week's time, because you can get an increased risk of suicide and suicidal ideation in that period. And it's really good to warn patients about it as well, because people who are warned about it tend to get in contact with their GP, and it helps reduce the risk of anything happening to the patient. Okay. Right, so moving on to obs and gynae and sexual health, there's quite a lot of obs and gynae that comes up within GP. There's a lot in terms of contraception counselling, subfertility, and also anything to do with pregnancy related illnesses, so hyperpressure, all that sort of stuff, and any kind of menstrual cycle irregularities, PCOS and things like that are really common topics within obs and gynae that come up in GP. Okay, so first question. A 22-year-old woman attends the family planning clinic inquiring about contraception. She's currently taking carbamazepine for epilepsy, and her BMI is 39 kilograms per meter squared. She has no other past medical history. Which of the following would be the most suitable contraceptive to offer her? And just give you a little bit longer if anyone wants to put anything in the chat, any answers. Okay, so this is a little bit of a harder question. So the important thing here was that carbamazepine is an enzyme inducer, and hormonal contraceptives are not very good with enzyme inducers because the efficacy is reduced. So the best, most suitable contraceptive here would be the IUD, the copper coil. Now, in terms of hormonal contraception, you have the UKMEC criteria, which you can look up online. It's very extensive. You don't need to know all of it. But you just need to understand that there's UKMEC 1, 2, 3, 4. And it sort of ranges from not contraindicated to completely contraindicated, never give it, with, you know, times where it would be advised against or giving because they're at higher risk. So UKMEC 4 means it's absolutely contraindicated, do not give it. And in terms of combined contraception, so commonly the COCP, if you have anyone who has a past history of breast cancer, I know there's not a picture on here, but if someone currently has breast cancer, you do not give them any combined contraception. If they're greater than 35 and smoke more than or equal to 15 cigarettes a day, very niche one, but that's just on the criteria, and so important if you're counselling someone on contraception that you're asking them these questions to show that you know that you wouldn't give it in that case. And so if someone's breastfeeding and they're 0 to 6 weeks postpartum, you absolutely can't give it, but after 6 weeks it decreases down to UKMEC 2. So if the patient really wanted it, then you would sort of warn them, but it is okay to give it then. And the other one that everyone tends to remember and know is migraine with aura. It's absolutely contraindicated, and if someone has a current VTE or a known sort of thrombotic risk. Okay, in terms of UKMEC 3, so this is when you'd be advised not to give it, but it's not absolutely contraindicated. So if someone has a BMI greater than 35, and if someone has hypertension, so high blood pressure, you really not thinking about it, giving it, and that's why you need to check people's blood pressure every year when they're on the pill. And if someone has a known is a known carrier of BRCA1 or BRCA2, or if they've had breast cancer in the past, then it's UKMEC 3, or a family history of VTE. And there's also things like long QT syndrome, which are slightly more niche, but you can go and read through these guidelines. They're quite easy and comprehensive, but don't get overwhelmed by them because there is a lot on there. It's just knowing the important UKMEC 4 and 3. Okay, so next question. A 14-year-old girl attends the GP surgery requesting the oral contraceptive pill. She's sexually active and her boyfriend is in the year above her at school. Her parents are unaware of the appointment and her request for the oral contraceptive pill. What is the most appropriate action? Okay, any more answers? Yeah, we've got B, C, another C, more C. Okay, yeah, so the answer here is C. And that's because what this question is getting at is the Fraser guidelines. So in terms of contraception in young people, it's again quite a good thing that UCL likes to test because it covers both obs-and-gynae and peds. And if someone's over the age of 16, you're not really worrying about this. But when it comes to someone under the age of 16, you are looking at the Fraser guidelines. Now, if someone's less than 12, absolutely, you're contacting a safeguarding team, and there's sort of no circumstances really in which that would be deemed safe and okay. But that's quite clear cut in terms of your position as a doctor reporting it to the safeguarding lead. Now, with all patients, you would want to, when you're taking a history, sort of make sure that they are feeling safe. And, you know, it's obviously a very different story if you've got a 14-year-old with a 14-year-old or a 15-year-old partner, or if you've got someone, a 14-year-old with a 30-year-old partner. But in general, when it comes to the Fraser guidelines, these are guidelines that are given that say that if you have someone between 13 and 15 and they can understand the advice given, they can't be persuaded to inform their parents. So you should generally sort of maybe ask why they don't feel they can inform their parents, and sort of encourage them to. But if they can't be persuaded, but they're likely to continue with sexual intercourse and their physical mental health is at risk with pregnancy, then, and parental involvement is against their best interest, then it is okay to prescribe contraception. But it's quite important to make sure you do go through the Fraser guidelines within your history taking, just to make sure that they do sort of fulfill that criteria. But yeah, the answer was C, so you can give it, even though she's under 16. Okay, so next question. A 19-year-old student telephones you to say that she has forgotten to take one of her combined oral contraceptive pills, Microgynon 30. She is 18 hours late and on day 10 of her cycle. She had sexual intercourse yesterday. Which of the options below represents the correct advice? I'll give you a bit longer for this one because there's quite a bit to read. Okay, just give you a little bit longer to put, if anyone else wants to put some answers in the chat. I know we've had one so far. Okay, so yeah, the answer to this one is E. Now, I know that missed pills can cause quite a lot of confusion, but there's sort of a few important things to know. So the first thing is that the progesterone-only pill and the combined pill work slightly differently. So with the combined pill, a missed pill is if it's more than 24 hours late. So with her, I think she'd only taken it 18 hours late. So the general advice is to take the last missed pill as soon as you find out and you remember, even if that means taking two at once. But if you've missed two, not to take sort of three. You just take the last missed pill and continue. And if it's just one missed pill, then there's sort of no problems. you don't need to use condoms, emergency contraception isn't needed. But if there's 2 or more missed pills, that's when you need to work out what week someone's in, and that determines what you tell them to do. So for everyone, you would generally say use condoms for 7 days. But if someone's in week 1, you need to, you might need to give them emergency contraception if they've had unprotected sexual intercourse. So if they've had unprotected sexual intercourse, they've missed 2 pills in week 1, you want to give them emergency contraception. In week 2, it matters the least, because if you've had sort of 7 days of taking it, you're covered. So in week 2, no emergency contraception, don't really need to do anything else, but you would advise them to use condoms for 7 days. And in week 3, they don't need emergency contraception, but you would tell them to skip the break between the next pill packet and use condoms. And for the progesterone only pill, again, it depends on which one. So with Micronor, Norethrestor, I'm really struggling to say that one, you're late if you take it more than 3 hours after you're due to take it each day. And for desogestrel, it's after 12 hours. But the advice would be to take your last missed pill, use condoms for 2 days. And if you've had unprotected sexual intercourse within 2 days of the missed pill, then you would give them emergency contraception. So in terms of emergency contraception, I think what Jane Kavanagh teaches you to do, which I find very helpful, is to draw your sort of line of last day of menstrual period, work out, that's day 1. Then you want to work out someone's pregnancy risk. So the general rules are that sperm survives for 5 days, and it then takes 5 days to implant. So you would put your sort of first day of last menstrual period, you would work out what day we're now on based on when their first day of their last menstrual period was. And then for each person, their earliest ovulation is their cycle length minus 14 days. So if someone was to tell you that they had a cycle length that varied between 28 and 32 days, you'd go with 28 because the earliest they could have ovulated is 14 days before that. So you would want to mark when their ovulation was. And then working out when they've had unprotected sexual intercourse and if they're at risk of pregnancy because they've had unprotected sexual intercourse within the last 5 days, or they've ovulated within the last 5 days and had unprotected sexual intercourse, then you would want to give emergency contraception. This is a really classic OSCE station because it's quite good at incorporating both history taking and also deciding which emergency contraception to use. When it comes to emergency contraception, there's 3 types. So the IUD, which is the copper coil, which is not the same as the IUS, the Mirena coil, but the IUD is the most effective one. So someone's just asked if someone has ovulated, they should use emergency contraception. So talking about if someone's missed 2 pills and you're giving emergency contraception, this is if someone has had unprotected sexual intercourse, they're not on any contraception, and we're just talking about normal emergency contraception. So it depends when they've ovulated and when they've had unprotected sexual intercourse. So if we're on day 14 and they ovulate on day 15 and they had unprotected sexual intercourse the day before, they are at risk of pregnancy and you would want to give emergency contraception. The sort of important bit is working out whether or not they are at risk of pregnancy. If you were on day 1 and they had their last menstrual period, started I'll say they're on day 3 and it started 3 days ago, they're not at risk of pregnancy if their earliest ovulation date is more than 5 days away, because the sperm only survives for 5 days. So it's not if they've ovulated already. So yeah, if they've ovulated already, and if they've ovulated already, like maybe a few days ago, they've had unprotected sexual intercourse, and within the window of either 5 days before ovulation or post ovulation up until now, then yes, they need emergency contraception, but it's just working out which emergency contraception they need. Does that answer your question? Okay. Yeah, it is really helpful to draw it out, because then you can see, okay, the sperm survives for 5 days, the fertilized egg takes 5 days to implant. Are you within that window? So the IUD can be used up to 5 days after unprotected sexual intercourse, or up to 5 days after the earliest ovulation, whichever's the later point. So even if someone had had unprotected sexual intercourse 7 days ago, but you're 3 days after ovulation, you can still give them the IUD. It's the most effective one and prevents fertilization and implantation. And it's important to tell people that it's not the same as an abortion, because it works before implantation. And if someone has a high risk of STI, you might want to give them antibiotics. And it's also good because it can be left in and work as long-term contraception. So some people really like it. Obviously, some people don't like the IUD. So your 2 oral morning after pill options are Ellaone or Levenel. So Ellaone can be used up to 5 days after unprotected sexual intercourse. It's more effective than Levenel, and it works by delaying ovulation. So if you have someone who is quite a few days post-ovulation or 3 days post-ovulation, you would want to counsel them and say that it is likely to be less effective because it works to delay ovulation, and there's a good chance you've already ovulated. And that's where it's sort of important to work out where someone is on their scale of having ovulated or having had unprotected sex. And it's contraindicated with oral steroids, so for asthma and enzyme inducers, or if you've had hormonal contraception in the last 7 days. And you would advise people after Ellaone to use barrier contraception for 5 days and discard breast milk for 7 days. And then Levenel is the least effective option, and it can be used up to 3 days after unprotected sexual intercourse. And I should say, with both Levenel and Ellaone, they're most effective the earlier they're used. So if you're getting 3 days on rather than day of, they do get less and less effective. So it also works to delay ovulation, and enzyme inducers can double it, and it can be given more than once per cycle and is safe with breastfeeding. And the sort of niche important thing to know that if someone's weight is above, or BMI is above 26, then you want to double the dose of it. Okay, and again, just cautioning the patient that there are sort of side effects of headache, nausea, sometimes quite a painful period. And if there's any vomiting within 3 hours for either of the morning after pills, Levenel or Ellaone, they need to repeat it and come back, and you want to get them to do a pregnancy test in 3 weeks. And the next period might be irregular. Okay, and yeah, so this is just a bit more about emergency contraception, and you'll get these slides so you can read through them, but I would really recommend Jane Kavanagh has a very good teaching session on it, where she goes through that, working out whether or not someone needs emergency contraception, and if they do, which one. Okay, so next question is, a woman and her male partner attend clinic. They've been attempting to conceive for 6 months, but have so far been unsuccessful. Both are anxious to be referred to secondary care for further investigations. Which of the following factors would not prompt early referral? Just give people a few more seconds if they want to put some answers in the chat. Okay, so we've had some C and A. And the answer to this one is C. So in terms of subfertility in the GP setting, you want to inform patients that 92% of people conceive within 2 years, and to try and optimize lifestyle factors. So if someone has a high BMI, advising them to lose weight, and psychological stress management. And just as sort of a side note, NICE doesn't recommend use of ovulation detection methods to time sexual intercourse. I think often that can make patients more stressed, which sort of feeds into the psychological stress management part. So when do you want to investigate? You want to investigate generally if they're infertile after a year. And that would involve screening both partners for STIs, looking at mid-luteal progesterone, serum progesterone, thyroid function, prolactin, and also semen analysis. But there are some times where you would investigate early, which was what the last question was sort of getting at. So for women, if they're over the age of 36, if they have menstrual irregularity, previous pelvic inflammatory disease, because it can make it more difficult for them to conceive. And for both men and women, if there's a history of STIs or abnormal genital exams, pelvic surgery, or any sort of known reasons that might cause infertility. And for men, if they have a history of varicoceles. Okay, so I think that's the end of my part. And yeah, if people would take a few seconds to fill out the feedback form, that would be really appreciated. And if there are any questions, feel free to send them through. Okay, and I will just stop sharing so that next tutor can. Oh.
Hi everyone, I'm just gonna attach my slides. Okay. Can you see that, the hematology slide?
Yeah, we can.
Great. Okay. 1 second. Just gonna make sure I can see the chat box. Okay. So my name's Marit. I'm also one of the final years. I'm just gonna try and go through this pretty quickly, doing hematology, urology, ophthalmology, and neurology in GP, of course. So for the questions, I'm not going to read them out. I think it's better if you read it yourself, because kind of like that's what happens in exams. And then just say your answer in the chat when you're ready. Just, yeah. Okay, so with that, let's get started. Okay, so if anyone knows the answer, just put it in the chat, or even if you just want to guess, go ahead. Or you can say it too if you'd like. Yeah, I can't see anything, so I'm just going to move on. Don't want to put no on the spot, but okay. So the answer is the FIT test. It's for a couple of reasons. So first of all, you want to look at the age. So this woman is 67 years old. And then looking at the blood results, what can people tell me? Does anyone know what this is? Like, what's abnormal? Yeah, exactly. So it's normocytic anemia, low hemoglobin, and the ferritin is high, so that it's not iron deficiency anemia. So basically, this is just another kind of test of the guidelines of colorectal cancer. So moving on to that, basically just if they're over 60 and they have iron deficiency anemia, you just go straight to 2-week wait. But if they're over 60 with just an anemia without any iron deficiency, you still actually do a FIT test to kind of rule out any cancer. And then for the rest, I think the others covered this in terms of kind of the 2-week wait of colorectal cancer, in terms of unexplained weight loss and abdominal pain. So I'm not going to go through that again, but here it is if you'd like. And then, yeah, okay. But it's just to point out that sometimes iron deficiency anemia can be a sign of cancer, basically. Okay, next one. Okay, so if anyone knows the answer, feel free to put it in again. Or just direct message is good too, if you prefer. Okay, so I'm going to start before I reveal the answer. What are the important findings on this kind of these results, these blood results? And does anyone have any idea what could be going on? Okay. And does anyone kind of know the diagnosis of what could be happening? Okay, so Yeah, exactly. So multiple myeloma. And you can see that because quite a few things here. So I don't know if you remember the multiple myeloma, there's an acronym for the main features. And basically anytime someone, especially an older person, presents with back pain, just try and go through that. And if there's a couple of the features, and it's quite likely they're trying to hint you towards multiple myeloma. So the acronym's CRABBI, CRABBI. So the C is for calcium, so hypercalcemia, as you can see here. R is for renal function, so the renal function is a bit low here. A is for anemia, so yeah, there's slight anemia here. B for bleeding, so they can have low platelets as well, so that can cause some bleeding or bruising. B for bone, like bone pain, so back pain here. And then I for infection, because it can also get infections as well. And you can see there's a bit of a low white cell count here. So it's kind of hinting to that. Now, all of these kind of make sense. Arrange a referral to a hematologist, go to the hospital, do these important tests to do multiple myeloma, except maybe don't discharge the patient home. So how do you kind of figure out what you need to do? Well, it's kind of, again, you have to refer back to the guidelines for this. So I'm just giving you the answer. So the answer is arrange urgent hospital admission. And the reason for that is the hypercalcemia. So it can be quite dangerous, actually. And so that's why you admit to hospital. So if there is multiple myeloma with hypercalcemia, so more than 2.9, like severe, AKI, or symptoms of spinal cord compression, so cauda equina, as Emma went over just now, then you want to admit them to hospital urgently. Otherwise, you still do these urgent blood tests, as you can see, the serum electrophoresis, to kind of figure out what's going on. And just like with a lot of hematological diseases, it's always good to do full blood count, blood film. On blood film, you could see something like a rouleau formation, which is like a little stack of coins. And then the main thing, which is always like one of those buzzwords, is the Bence-Jones proteins that are associated with multiple myeloma. Okay, so I think that's good for now. Let me know if you have any questions. Okay, next one. Okay, what's the single most appropriate investigation as the next step? Okay, so really important to read the question here always. They like to trick you by asking a specific question in SBAs all the time. So what do we see? There's not really any red flag features I can see here. It's a 40-year-old man, so we're not really thinking about bowel cancer too much, but always want to keep it at the back of your mind. And he's got kind of like a vague symptom of being tired and intermittent diarrhea, and this iron deficiency anemia. So the answer is actually celiac screen, and it's just kind of to point out that celiac disease is kind of a relatively common cause of iron deficiency, so it's always good to rule it out before worrying about anything bigger. But does anyone know what kind of a celiac screen involves? Yeah, exactly. So it's tissue transglutaminase and IgA, and total IgA. So tissue transglutaminase antibodies, specifically IgA antibodies, and the total IgA. And the reason you have to do the total IgA is because if the total IgA is low, then the tissue transglutaminase IgA will be low as well. So you might get a false negative when really they do have antibodies. Hope that makes sense. And then does anyone know? So here's just, these kind of features can be associated with celiac disease. So it's quite vague. It's kind of like vague abdominal symptoms, fatigue. If anything just doesn't seem quite right in the history, just that kind of thing. And also if they have a family or personal history of autoimmune disease, that can also be associated. Okay. So investigation, the tissue transglutaminase is first line, and then you do a endoscopy for the formal diagnosis usually. And even if the serology, so the antibodies are negative, you can still consider the endoscopy, but usually you don't need to worry about that too much for exams, I think, but you can still consider it if you are really suspecting celiac. Does anyone know what you would find on an endoscopy? No? Okay. So endoscopy, you do the duodenum usually, sometimes jejunum. And you would find villus atrophy and crypt hyperplasia. So it's always good to kind of know that in case it comes up in exams, and also increased lymphocytes, but I think that's not really one of the buzzwords. Oh, and then, this in red here, don't forget the patient needs to be eating gluten for 6 weeks, otherwise the test will show up negative. Well, they might. Okay, next one. Okay. Anyone have any ideas? Again, just type it in the chat. Okay, so I'm just going to move to the answer. So it's a hemoglobinopathy. So again, what points to it? Well, it's a young woman, young Asian woman. They're more likely to get certain hemoglobinopathies. And then the hemoglobin's low and the mean corpuscular volume is low. So it's a microcytic anemia. And the serum ferritin is not really low, so it's not really likely to be iron deficiency. And the main two causes of microcytic anemia are hemoglobinopathy and iron deficiency. And I'll go through what the other ones would be later in the diagram, so don't worry about that. Okay, next one. Yeah. Does anyone know what the answer is? Okay. I feel like the slides have kind of given it away, but it's colorectal cancer. So again, hemoglobin is low. The mean cell volume is low, but the ferritin's low as well. So it's kind of a sort of iron deficiency anemia. But it's a 67-year-old woman and she's having fatigue. So you would suspect possibly a colorectal cancer due to a bleed causing the iron deficiency. Okay, so quickly going through anemia in general. First, you want to categorize it. Is it microcytic, normocytic, or macrocytic by looking at the mean cell volume? Yeah. Then if it's microcytic, it's usually either iron deficiency or hemoglobinopathy, such as thalassemia. You can just kind of decide that by looking at the ferritin. So if the ferritin is low, then it's iron deficiency. If it's normal, then it's maybe more likely to be hemoglobinopathy. You might want to do a electrophoresis. Then normocytic, you have usually things like hemolysis, blood loss. Chronic conditions can also kind of present as normocytic anemia a lot. And then you've also got kind of like your cancers, your blood cancers. And you can look at the reticulocyte count. So reticulocytes are kind of developing blood cells. So if you're losing a lot of blood or you're breaking down a lot of blood, breaking down a lot of red blood cells, your body will produce more new red blood cells. So your reticulocyte count will be higher. Whilst if you have cancer, really, you've got a lot of bone marrow dysfunction, so your body might not be able to produce any reticulocytes, so it probably won't be elevated. And then also with the leukemias and such, usually you'll have some of the other parameters will also be kind of messed up, like the platelets or the white cell counts and things like that. And then macrocytic anemia is usually folate or B12, so just measure that. And it's usually one of those deficiencies. So B12 can be like pernicious anemia. Okay. Next question. Okay, so can anyone tell me what kind of anemia this is? So it hasn't given the parameters actually, but it's normocytic anemia. And then yeah, tell me what you think the answer could be. Yeah. So C is right, exactly, according to the algorithm. So if you follow that. And then you've got some other clues in here. So the clue here is the valve replacement can cause damage to red blood cells, and that can actually cause the hemolytic anemia. So that's why it's happening. And also, like, the platelets are normal. White cell count is fairly normal. So it's unlikely to be kind of a leukemia or anything. Okay. Okay, does anyone know the answer? Okay, so the answer is chronic lymphocytic leukemia. Just going to point out a couple of things here. So her age, chronic lymphocytic leukemia is usually in older people. In lymphocytic leukemia, you usually have elevated lymphocytes. Kind of obvious, but here it is, which you don't have in acute myeloid leukemia. In terms of kind of like differentiating myeloid and lymphoid, so those are kind of two precursors to a bunch of cells. So the myeloid lineage leads to blood cells like red blood cells, platelets, and then your like basic white blood cells like neutrophils and macrophages, whilst the lymphoid lineage leads to basically B cells and T cells, or your lymphocytes. And they usually cause it to be elevated, but they also usually cause dysfunction with the other groups. And in myeloid leukemia, you'd have everything would be really deranged and you wouldn't have a high lymphocyte count. Another thing, the lymphadenopathy can be a sign of these kind of leukemias. And okay, does anyone have any questions about that? I think if you, just compare those a bit side by side, I guess. Okay. Does anyone know the answer? C, that's a good guess. So the answer is actually E, but C is a good guess. I actually thought that at first as well. But so clearly this boy has quite significant symptoms. The fatigue and the pallor suggest a sort of anemia or low red blood cell count. Easy bruising suggests his platelets are low as well. So we're really thinking about leukemia here. And then petechiae. So I think according to these guidelines, the reason that he needs to have a same-day admission to hospital is because of these petechiae, because I think it suggests it could be quite bad bleeding risk, is my guess. And then you've also got hepatosplenomegaly, which I'm not sure about. But yeah, just any kind of symptoms that involve low red blood cells, low platelets, or low white blood cells like infection that are unexplained in a child are always a bit worrying, and usually do an urgent full blood count within 48 hours, unless they have the petechia and then they go to hospital. Okay, so that was hematology. I'm going to move on to kidney neurology now. Okay. If anyone knows, feel free to put it in the chat. Okay, so the answer is 4 weeks. It's basically just a bit of rote learning of the PSA. PSA is prostate-specific antigen and can be used to kind of hint towards prostate cancer. Problem is, it can cause quite a lot of false positives, and it can, like, there's certain things as well that make it even more likely to have a false positive, and that can lead to unnecessary tests. So NICE doesn't really recommend it for a screening program, but it does offer it if people ask. So in terms of the question, if you have a UTI or prostatitis, then you have to postpone the test for at least a month. If the patient has recently ejaculated, has any vigorous exercise, or if you've done a prostate exam, you also need to wait 48 hours. And then urinary retention, urinary tract instrumentation, and BPH, and of course prostate cancer can all cause raised PSA levels. Okay. Okay. Can anyone tell me the answer, or tell me what kind of incontinence this is? Yeah, exactly. Stress incontinence. It's really good. Do you know that? I think this is quite, like, incontinence is quite an important one because it's very easy to test in exams, and the management for stress and urgent incontinence is actually different. So it makes it kind of interesting for UCL, I think. So does anyone know the answer to the question? Okay. So the answer is refer to physiotherapy, and that is actually for pelvic floor training. So that's what the physiotherapist does in this case. So I'm just going to go to here. First, I'm going to quickly explain the difference in case people didn't understand. So stressing, when you think about the bladder, it's important to think you've got two important muscles. So one is the detrusor muscle, which kind of contracts when you're emptying your bladder, causing you to release urine. And then there's the sphincter muscle, which is contracted most of the time to prevent any urine leaking out. So dysfunction in these muscles can cause the incontinence. So stress incontinence is the one with the sphincter being too loose. And that's caused by the pelvic floor itself being a bit weakened. So things like pregnancy can weaken that, or just old age as well. So a lot of older women get it. Postmenopausal women get it. And then urgent incontinence is because of the overactivity, kind of the detrusor muscle. So it kind of contracts when it's not supposed to. And so you might get more like significant volumes coming out sometimes. While stress, you tend to get more leaking, especially when you are like coughing or sneezing or kind of causing pressure on the sphincter. So I hope that helps kind of understand the difference. And then in terms of management, so stress incontinence, as we had in the lady above, because she had it when she was coughing, sneezing, or laughing. So first, it helps if you lose weight for both of them, because it releases the pressure on the bladder a bit. But conservative management for stress incontinence is try to reduce caffeine, and then meanwhile the first line treatment as well is this physiotherapy with pelvic floor training. And to say you've properly tried that, it has to be for at least 3 months. at least 8 contractions 3 times a day. So that's kind of like in the NICE guidelines, they have to have done that. But yeah, I don't know how strict that really is in real life. And then if it's beneficial, they continue with that. If not, they can move on to medical management, which is duloxetine. And then I believe there's actually, if that doesn't work, you can move on to like a vaginal tension tape as well for surgical management. And then in urgent continence, it's kind of similar. Start with conservative management, where you do bladder retraining for at least 6 weeks. And bladder retraining is just increasing the amount of time between using the bathroom. So kind of to build it up. And it does seem to work for some people. And then you've got the pharmacological treatment, which is basically just to prevent that detrusor muscle from contracting too much. Urgent continence is also sometimes called overactive bladder, by the way, which you can see why. So oxybutynin, which should be avoided in frail older women, I think because it makes them dizzy, I'm pretty sure, but I'm not really sure. And then tolterodine and daraphenazine. Okay. Next question. Okay. Does anyone know what is going on, and then what the answer is for the single most appropriate initial investigation, initial management, sorry. Okay, so this is a really important medical emergency or surgical emergency. It's testicular torsion. It's common in young boys. It happens more in young boys than in older people, but it can happen at any age technically. Yeah, it can be associated with nausea and vomiting. It's very severe pain on one testicle usually. The testicle probably won't feel hot or anything, but it will be very tender to touch, and it should be like raised and twisted. And then the management is, it has to be referred as an emergency to urology, or the testicle could become ischemic and die, and then it needs to be removed as well. And that can occur within as quickly as 6 hours. So it's really, really urgent that gets seen, and it's better to take the risk and refer to the urology team. And what they will do is an exploration of the testicle and an orchidopexy, which is when you tie the testicle down. And actually, it gets done in both testicles to prevent happening the other one, because once they've had it in one testicle, it's more likely that will also happen in the other one. Oh yeah, so here's the twisting of the spermatic cord. There'll be a loss of the cremasteric reflex, which is when you stroke along someone's thigh, a man's thigh, that their testicle will move up, so that won't happen anymore. I don't know if anyone really does that because they'll be in so much pain, but and then the big differential for this is epididymitis, which is kind of inflammation of the epididymis. And in epididymitis, it might be more warm, more red, and also there's something called Pren's sign, which is if you lift the testicle, it will relieve the epididymis and therefore it will relieve the pain. But really, it can be difficult to tell sometimes. So it's better to take the risk and do the surgical exploration. If you think it's epididymitis, but you just want to, just in case, rule out torsion, you can do an ultrasound as well. Okay. Next, ophthalmology. Does anyone have any questions about what we just talked about or anything else? Okay. Next question. Okay. Anyone know the answer? Okay. So hot compression and massage. So this is a chalazion, which is kind of just a bit of inflammation of like the oil gland. And it doesn't require antibiotics. They're pretty clear about that, unless it gets really bad, but it shouldn't usually. It's very common and really just needs hot compression and massage. Yeah, so don't think it's more than it is. I guess the other thing you could confuse it with is a sty, which you can see here. A sty is kind of inflammation of the eye, inflammation or infection of the eyelash kind of gland. You don't usually use antibiotics for this either, unless they are unwell. Yeah, and usually it's also just warm compress for this. If the chalazion got bad, you could also do incision and drainage if it's needed. Okay. Next one. Okay, so the answer is referred to an ophthalmology unit because this is ophthalmia neonatorium. So yeah, the patient has an inflamed conjunctivitis, discharge, and sticky eyes. It's because the baby is so young that you should suspect kind of a sort of quite bad infection that could be passed on from the mother. So things like chlamydia, gonorrhea, strep, or staph infections. And they should always be an immediate referral to the ophthalmology unit. I feel like it was kind of given away, but okay, next one. Yeah, so you're right, the answer is E. Oral acetazolamide and topical pilocarpine. So this is acute angle glaucoma, closure glaucoma. It's a very important diagnosis. Usually just refer immediately to ophthalmology but obviously here it's not possible. I would say there's a couple eye drops to learn for this one. Usually I feel like the past-med one on this one is quite good, so maybe have a look at that, and it explains all the eye drops in detail. I don't really have a diagram here, but, or maybe I do. Oh yeah, so we've got acetazolamide, reduces the intraocular pressure by reducing aqueous secretion. And then topical pilocarpine causes pupillary restriction, which kind of opens the angle of the eye. Oh, sorry. And then in terms of ophthalmologists might also use timolol, which is another kind of eye drop, topical eye drop. But like I said, I think Passman has quite a good summary on this one. And then the definitive management you also have to remember is a peripheral laser iridotomy. Okay. Neurology. This is our last subject, so almost there. Okay. Yeah, I feel like does anyone know the answer? I feel like it's kind of been given away a bit. Yeah, good, Claudia. And Manor. Yeah, so it's migraine. It's the only one that doesn't have an explanation next to it. So I guess when you talked about headache, I guess here the things that point towards it being a migraine are the throbbing sensation around the eye, and then also the phonophobia, so the noise. Other things which are very common usually are photophobia, so like they can't handle lights and they usually go into kind of like a dark, quiet space to lie down. Yeah, and also it's more common in females as well. And yeah, it says here all the other reasons why the other ones aren't, if you want to read that. Okay. Next one, another headache. Yep, you're right, Avina. A space-occupying lesion is the most likely diagnosis. Why? Because a space-occupying lesion can cause a raised intracranial pressure. None of these other ones would really do that. Viral meningitis, very unlikely, and the other ones are just different types of headaches. So the reason we think space-occupying lesion, does anyone know what kind of things, why do you think that? Yeah, vomiting. Yeah, exactly. Yeah, so those are the key findings. Recurrent vomiting, especially, is very worrying, especially when she doesn't have a fever or any kind of gastrointestinal symptoms, but she does have this severe headache. Worse in the morning is a sign of a space-occupying lesion. So a real red flag. And also when she's resting on the bed, because the fluid kind of goes to her head and makes it worse at that point. And then, yeah, she's been bumping into things while walking. So it's kind of some neurological signs there that you're seeing. So yeah. Okay. Here are some headache red flags. Bit vague, but systemic signs and disorders, neurologic symptoms, new onset or changed, and patient is more than 50 years old, a sudden presentation, papilloedema, pulsatile tinnitus, positional change, like you said, Evelyn, and precipitated by exercise. Okay, next question. Okay, does anyone know the answer? Otherwise, I'm just gonna move on next. Yeah, C. Oh, sorry, you said some stuff already. Didn't see that. Okay, yeah, it's gabapentin. So it's just testing your knowledge of neuropathic painkillers. So sorry, almost done. So yeah, the first line treatments are any of these 4 drugs, so amitriptyline, duloxetine, gabapentin, or pregabalin. Then if one of them doesn't work, you try one of the other 3 drugs. Rescue therapy is tramadol, and you can also use topical capsaicin for neuropathic pain. Going back to these other ones, I mean, lidocaine's an anesthetic, of course. Carbamazepine can be used for trigeminal neuralgia only. It's first line. Topiramate for a certain type of headache. Yeah. And like I said, topical capsaicins more for like a localized specific pain. Okay. Next question. Does anyone know what this is? Yes, exactly. It's a TIA. So anyone know how soon he needs to be seen? So within 24 hours, anyone who has had symptoms of a TIA within the last week has to be seen within 24 hours. And does anyone know what you can give them? Well, I've already kind of given it away, but yeah, so you have to give them 300 milligrams of aspirin immediately, unless they are taking an anticoagulant already, or they have a bleeding disorder, or there's some obvious other reason. Okay. Yeah, and that's the end of the presentation. Hope you guys all survived that. Thank you for listening, and if you could fill out this feedback form as well for me, that would be great. Thank you. Yeah, feel free to log off when you're done with that. No worries. Enjoy your evening. Emma, are you still here? I don't know. I feel like there are these YouTube videos. Let me ask one. Muriel, do you remember those GP YouTube videos we used to watch last year? Do you remember what they're called?
Oh, no, I don't. What are you talking about?
There are ones that UCL recorded. Splice, yes, Splice, GP Splice on YouTube. They do lectures for every specialty. They're quite good. I would recommend them. Okay. I'm going to stop the presentation now.